Good afternoon, everyone. It's great to kind of be later in the day because you get a chance to reflect on everyone else's presentations. And the most I have to say I have very mixed feelings right now. I have a lot of excitement, a lot of enthusiasm because I feel like there's a lot of phenomenal themes that are cross-cutting, and there's so many phenomenal organizations that are taking on, I think, what are the most important issues in our healthcare delivery system. The reason I have mixed feelings is because I started this morning at the Health Data Palooza. And the Health Data Palooza is held at the Hilton on Connecticut Avenue, where they have enormous ballrooms. And I have to tell you, there were like 3,000 people there this morning. I had the privilege to speak there for about 5 minutes, and I'll give you guys the slightly more extended version here. And the difference in attendance is actually quite concerning to me. It's concerning because I think the real action is in this room. I think there's really important strides to be made around healthcare data, patient empowerment, the themes that are being discussed at that conference. And I'm thrilled that that conference has gotten the momentum that it has. But it leaves me wondering why this room isn't bigger, and why we haven't been able to actually garner the momentum that this field needs, that all the fields that have been discussed here today needs. And I'm really looking forward to the last panel, where I think we're going to have an opportunity to talk about some of the obstacles to scaling some of this type of thinking, because I actually think that many of the policy instruments are already in place, but really what we need more of is organizing, activism, political will. We need fewer publications. We need more transformation, and I think this is a room of people who are actually doing it. The question that we have to figure out is, how do we clone organizations like this, collaborate, not compete, and scale and make mainstream the types of thinking here that I think we're all seeing as somewhat exceptional. I'm really proud to represent CareMore. A lot of people, when they hear I'm at CareMore, they say, "That's fantastic, you're at this great startup company." And I have to correct them almost immediately and say, I'm actually just the recipient of a phenomenal legacy that started 25 years ago in Downey, California. How many of you have been to Downey, California? Wow. So I will tell you that's fantastic. It's usually not that many people, and I want to know you, and I want to know why you've been to Downey, California, because there's nothing that remarkable about Downey, California, except for the fact that it's the site of the oldest standing McDonald's. It is actually the site of the oldest standing McDonald's. It's also the site of the first Taco Bell in America, and it's also the site of the first CareMore Care Center. And I like to say that we have a virtuous business model. We've got some of our neighbors that actually create chronic disease, and then we are entirely committed to treating chronic disease. But in some ways, I think it's quite poetic that we sit across the street from this McDonald's. Just small kind of side point. Any of you seen the Michael Keaton movie, The Founder? So I have to say that movie is the healthcare movie of the year in 2017. And if you watch it, you'll see why. And very few people have actually seen this movie, but it's really about standardization, scale, process improvement. And I will tell you, one of the things we've gotten wrong in this industry is that we have created this whole jargon around lean and A3s and A4s. And save yourself a lot of consulting money, make your company watch the movie The Founder, and I promise you it'll be transformative. It's something that we're doing a lot of at CareMore right now, and it's changing the conversation around how do you take an organization that started at one care center in one geography and make it a national phenomenon. But I want to tell you a little bit about Shelley Zinberg. Have any of you met Shelley Zinberg? I know Michael has. You have as well. So this is probably the most visionary healthcare thinker that you've never heard of. He is a remarkable person. A colorful character is probably the understatement of the year. He grew up on the streets of Newark, New Jersey. He was a dog trainer to local mafia enforcers. He was a college student. I think he was at Seton Hall in New Jersey, and visited his uncle, who's an osteopath, and said, "Wow, this is phenomenal." He really liked primary care. He felt like it matched his personality. So he went to medical school, paid his way through by working as an amateur prize fighter in Philadelphia. True story. Moved to Southern California for residency and fellowship in gastroenterology. And at the young age of 60, started to get really frustrated with clinical practice. Where he once found joy, he saw frustration. He would, see things like, patients with ESRD, and he asked himself the question, why? Because he knew that these were preventable complications. He saw retinopathy and patients going blind in Downey, which, to give you some perspective is, it's a lower middle class community, 70% Latino, average, per capita income is about $18,000. 11% of the population lives in poverty. And he said, we could do better for these people. He also had the observation, and at this time, 1993, this was totally heretical, that all patients are not equal. And it went against the egalitarian ideal that we have in healthcare to actually say that all patients are not equal. But he said the sickest of our patients actually need more attention, and they need a different model of care than the less sick patients. And then he also did something that I think was pretty clever and I guess timely for him, was he started to look at care through the eyes of the patient, and he didn't like what he had to what he saw. What he saw was a disjointed care experience that was created by the fact that you had a different set of people taking care of you in primary care, a different set of specialists, different set of doctors in the hospital, different set of doctors in the SNF, different set of doctors seeing you in post-discharge follow-up, and he was seeing mistakes happening at every point of across the whole way. And so he started to dream about something different. And so he got together. He's a very social guy. I mean, he owned restaurants, and I think at the time he did own a restaurant. And he pulled together, 20, 25 of his best physician friends in the Downey Whittier region of Southern California, and said, "Let's get together and let's do something different." And he's a leader, so they followed him, and they said, "Okay, let's do this." And they came together and created what was called the CareMore Medical Group, and started to think about practicing differently. And went to Blue Cross, it was actually Blue Shield at the time, and said, "Give me 100% delegation of your premium dollar, and let me see if I can do something different." And predictably, he screwed up. He made a lot of mistakes. And in the first years of the CareMore Medical Group, they lost $12 million, and and Michael's going to laugh right now because Michael's an ex-CareMore person. This is a colorful group of people. They almost deposed him as their leader a few times. His son ended up suing him. I mean, there's all this great drama. One day I'm going to make a movie called The Wolf of Healthcare, and it's going to star Shelley Zinberg. But he stuck with it. He kept everyone together. And before long, they really figured it out. And they figured out that ultimately, you needed to do a couple of things differently. One is you need to actually prevent people with chronic disease from progressing. That if you actually intervene at stage 1, 2, or 3 CKD, that you could actually make it so that your patients almost never go on dialysis. He also, is a lifetime fitness enthusiast. And so he tried to take his own values around fitness and confer them on patients. And so built fitness facilities that were attached to clinical care centers and prescribed exercise as a therapy for his patients. He built chronic disease management programs. Himself being a specialist, he said, us specialists, we get it wrong a lot of the times, and we don't actually envelop our patients with the kind of care that they need. And so he took all the things that you would love to have in a primary care center, in a primary care practice, that you would never be able to do, for your patients in a single, onesie or twosie practice setting, and put it all in a medical home co-op that he called a care center. And so he had, a care center that existed outside the walls of a primary care practice, where there were dietitians, nurse practitioners trained on chronic disease management. He had podiatrists to do foot care. And all of a sudden, you had this very vibrant neighborhood-based care center that had nothing to do with your primary care office or your specialist offices, where where we do chronic disease management. And he actually invented some new roles. This is this is the new fad right now. Everybody's got an IST, and CareMore's IST was the extensivist, and this was a physician who would follow a patient. And I want to say, in fairness to Shelley, this happened before there were hospitalists. This was around the time that Bob Wachter was coining the term hospitalist. Shelley just never wrote any papers, and so he was never able to get this term, into practice in the way that we needed to. But he essentially created a specialist physician who was an internist who would see patients in the hospital, follow them to the SNF, and see them in post-discharge follow-up. And in the process, he was able to shorten lengths of stay. And, for these complex polychronic patients who show up in the emergency room, who will almost invariably get admitted because every ER doc is seeing them for the first time and admitting them on the spot, having, an extensivist in the hospital who knew the patient would oftentimes avoid unnecessary hospitalizations. And so on every one of these avoided admissions, there was probably $10,000 or $12,000 of medical savings. And then because it was the same doctor who was actually seeing the patient in the hospital, in the SNF, and in post-discharge follow-up, they were able to move them along the continuum of care faster because they knew that a person who knew the patient was actually inheriting them down the stream. And so, ultimately, he built this whole model of care that was quite remarkable, and they actually did quite well. And you can see kind of the overall map of the model of care right here with the extensivists, the primary care physicians, the care centers, and really case management wrapping around the whole thing. And it was humming along. And then all of a sudden, this woman, Liba Lesson, any of you meet Liba, any of you know Liba, remarkable woman, kind of was doing a consulting project and stumbles upon CareMore and says, this is the answer. This is the future of healthcare delivery. And she had to buy it. She just knew she had to have it. And the funny thing about this is she, is a Whittier, California native. Whittier is adjacent to Downey. She'd never heard of it and just kind of bumped into it by accident. She was a seasoned managed care executive from Pacific Care and made an offer to buy it. And I think the first offer was for $4 million and, was rejected. And, 3 months of negotiations later, private equity investors and whatnot bought it for $250 million from Shelley and his partners. And I think Shelley brought bags of cash and handed them out to everyone. This is the kind of person he is within the offices of CareMore. So Liba's first year at CareMore was all about figuring out what the secret sauce was. And you've heard a lot about models today, and everyone's talking about models. And the model is certainly important, and all these models are very important. But I think her brilliant insight about what CareMore was that it was about culture. And it was about a culture that started with Shelley, but then permeated into every single person who worked in the organization. And it was whether it was the member services representative who enrolled you in the CareMore health plan, the person who answered the phones, the front desk, the physicians who worked on staff, the nurse practitioners, the podiatrists, everyone actually gave a damn. They cared a little bit more about their patients than you might expect them to. And there was a system that actually enabled them to be their best selves and practice at their highest level. But it was really about the culture of caring. And so she set about to scale this thing. And so before long, what it was 2 care centers in Southern California when she bought it, suddenly became care centers in Southern California, Northern California, Arizona, Nevada. And I think it was at about 26 care centers and 50,000 Medicare Advantage members, at which point she said, we've kind of taken this thing as far as we can. We need to think about, a different ownership structure. And so about 5 years ago, she and her partners sold it to Anthem as a Medicare Advantage plan and delivery system. Now, the hardest part about this, but also the most important part of this, is scaling this culture. You can't do this work unless you care. You can't be doing this because you want to have a liquidity event. You can't be doing this because you think that it would be cool to do it. You have to do it because it is what you want to do. You have to be super passionate about it. I think, I'm running out of time here, but I will say that the secret sauce isn't the model, everyone. It's not the payment models. It's not the policy. I will say, just being an observer and kind of a participant in this world, the secret sauce is actually building, sustaining, and scaling culture across multiple geographies. And that's a bit of what we've done at CareMore. We started in Southern California, went to Northern California, Arizona, Nevada, We're now in Virginia, in Richmond as a Medicare Advantage plan. We're working with Emory as their care delivery transformation partner and population health solutions provider. And being acquired by Anthem, one of the questions that Anthem leadership asked was, how can we take this and apply it to other problems? And you can imagine that if you could build a CareMore type model for Medicaid, there would be a lot of areas of crosstalk and a big crosswalk. And so we're now a Medicaid care provider in Memphis and in Des Moines, take care of about 25,000 Medicaid patients. And that is a population that needs a model of care like this more than anyone. And we've worked now with the age blind and disabled population and are making I think an increasingly significant impact working with those populations. I'll just share my observations as a relative newcomer to CareMore. I joined about 2.5 years ago as chief medical officer and became president about a year ago. I think it's all about more time. The culture piece is obvious. I think we talked about that, but when you can actually add more time to the care delivery system and actually give the patients who need more time, good things start to happen. And we have a clinical philosophy that's really built around never wasting any touches. If any of you have heard of the CareMore story before, you've probably heard about toenail clipping and probably get a little bit grossed out. But the toenail clipping isn't about the toenail clipping. It's about creating more touches with the system. So we provide monthly free toenail clippings for all of our members. And the point of doing that is to actually get them in so we can manage their chronic diseases and make sure we're doing foot care for diabetics and build a relationship with the patient. And what this is translated into is lower disenrollment rates. It's translated into better health outcomes. And it's translated into a clinical culture that is really about bonding with patients and doing what you can for them, whether it's giving them rides to actually come to and from their appointments, getting them an air conditioner if they're dehydrated in the summer months, building a ramp for them at their home if they're unstable on their feet and need some assistance getting in and out of their home. And translates into clinical results like fewer admissions, fewer readmissions, a lower length of stay, fewer hospital bed days, fewer ESRD inpatient days, fewer CHF admissions, COPD admissions. And this is all very exciting to us, but I will tell you one thing that is another part of the culture that I think I've discovered. I think it's probably Liba's contribution that kind of built on Shelley's contribution, is a commitment to never really be satisfied with anything. So if we get to a place where we've got 180 patients in the hospital, we're on 80,000 Medicare Advantage lives, we're wondering why it's not 150, and we're asking that question every single day. And we take a philosophical stance that every admission to the hospital is somehow a failure of what we're doing. We take the view that medication adherence is our problem, not the patient's problem. And we're operating in their socially complex milieu to try to do what we can to actually change their health outcomes. And these are some of the most worthy people. These are people who've contributed so much to society. These are people who have done a lot and need great health care. And I'm really very proud to have inherited this legacy. But I think the exciting place is now the conversation that we're having here today is, how do we make this the norm and not the exception? How do we get 3,000 people in this room and not at Health Data Palooza? Or we can have 3,000 people there too, but 10,000 here. Because I really do believe that the action is here. And this conversation is too much of a tasty side dish and not enough the main course. And I would ask you all to think about how you can make this the main course when you go back to your communities. So really appreciate the opportunity. Thank you.